So next I'd like to introduce Nathalie Lucas.
So I'm Nathalie, I'm a neurophysio. I work at King's College Hospital in London. Today I'm going to talk to you about the role of orthotics within our MND clinic and timely provision of these. As a physio myself within the clinic, my personal kind of role I feel is very much a commitment to people's quality of life and really prolonging that for as long as possible. So just a little bit about orthotics. So obviously the provision and the use of an artificial or mechanical aid, such as a brace, to prevent or assist movement to weak or injured joints or muscles. The NICE guidelines, which we use in the UK to make sure that all treatment is standardised, essentially, so that if a person with ALS needs an orthosis, to help with muscle problems, they should be referred to an orthotist, and they should be referred without delay. Orthotists at King's are contracted to provide patients in the NHS with orthosis as appropriate. Therefore, we were looking at the development, the delivery, and the initial evaluation of the introduction of an orthotist into our well-established MND clinic to offer prolonged function to patients. So hopefully by the end of the presentation, we'll agree that we should have an integrated orthotics and physio service available within MND clinics, appreciate the challenges of the outcome measures for patients within this group, and strive for more national and international advocacy for timely access to orthotics. But just going back to a bit kind of more the history around the project, so I'm a physio working at King's within the MND clinic. The clinic covers the southeast London, and last year had contact with 827 patients with ALS. Not all of those were seen by the physiotherapist, but that just gives you kind of an understanding of the size of the clinic. It was evidence from clinical experience and feedback from patients that the access to orthotics was poor in terms of geographical location, but also in terms of their timely access. The current service that we had is that physiotherapists have a very small stock of orthotics that we can give to patients. They're very standard, and the difficulties that we found was the compliance with these types of orthotics. They're quite cumbersome. We're not able to adjust them ourselves, so unfortunately a lot of patients didn't get on too well with them. So therefore we had to refer them to either their local orthotics or our orthotic service, which resulted in a 4 to 12 week wait. The background of this project comes from the patient experience. One particular patient that kind of resonated was a very young patient with a young family who came to see us via clinic. It wasn't appropriate, none of the orthotics that we had were appropriate for him, so we referred him to the orthotist. He was seen 6 weeks later, and by this time he'd had a few falls, he'd lost his confidence, and it's also likely that his disease had further progressed, and an orthotic was no longer appropriate for him. This particular experience really emphasised the need for timely access to the appropriate orthotic for the patients to make sure that we're optimising their function for as long as possible. It was an extremely distressing situation for the patient and the professionals involved, so that was the real reason behind this project. Prior to suggesting a new service, we had a look at an audit for the space of just 4 weeks within the clinic to see how many patients needed to be seen by an orthotist. New patients, 1.3 new patients a week required input from an orthotist, and on top of that, there was other patients who needed reviews and follow-ups. So the current service that we had was that the patients came to the ALS MND clinic. They were then referred by either the specialist nurses or the consultants to physio. We would then see them and identify the need to either refer them to orthotics or give them something that we had available to us. As mentioned previously, unfortunately, this resulted in a 4 to 12 week wait for the patient before they received their orthotic, depending on where they lived and the waiting lists and things. They were then given their orthotic, and that process took essentially up to 3 months. The service that we proposed was looking at orthotics integrated within our MND clinic to provide direct access. It would mean the patients could be assessed by an orthotist on the day that they came to clinic, and they would go home with the appropriate orthotic. So going home with an orthotic within 1 to 5 hours of arriving within the clinic, as opposed to waiting 12 weeks. The guidelines all talk about prompt access to orthotics, timely provision, and onward referrals. They all talk about time, but nowhere in the guidelines is there a definition or a standard for what timely means. In terms of the service evaluation, we looked at 2 different outcome measures. One was to look at the satisfaction of the orthotic service, and one was to look at the patient functional outcome. We had a sample size of 20 patients, which was convenient sampling related to the patient need and the time frame that we had, and also reasonable data from which to calculate the mean and effect size. The outcome measures that we chose to look at function was the Modified Activities Specific Confidence Scale, so the ABC. We chose it to capture patient function. We used the modified ABC, so we used 6 questions, of which we'll go through a bit later, which were most relevant to this patient group. It's a confidence rating scale, so hopefully looking at quality of life of the patients and their quality of their functional abilities rather than the quality of their actual movement or the activity. It's not validated in MND, but it has been validated for use in Parkinson's disease, which is also progressive, so it could be argued that it could be transferable between the 2. An MND-specific functional scale that has been recognised in the MND physio guidelines in 2014 is the ALS functional rating scale. We chose not to use this as only 2 items, which were walking and stairs, would have been appropriate to our patient group related to orthotics. Therefore, it probably wouldn't have been sensitive enough to pick up any changes. Then we also used the OPUS, the Orthotics Prosthetics Users Survey satisfaction, to look at service satisfaction of a new service that we were trying to implement. Here you can see the ABC, so the questions that we used. So the questions of it that we chose were to walk around the house, to walk up and down the stairs, to walk outside the house to a parked car, to walk down a ramp, and then to walk in busy areas with people kind of brushing past you or bumping into you as such. We chose the most relevant questions for patients wearing orthotics. For example, one of the questions on here is picking up a slipper from the floor, which people probably wouldn't be wearing their orthotic at that time when picking up a slipper from the floor. We completed this pre and post, giving them an orthotic to have a look at a change score to see if the orthotics made a difference. We also looked at the modified OPS to measure satisfaction of orthotics with a bias to fit and service provision. So we used 5 questions. The questions were related to the orthotic fitting well and the delivery of the service regarding the orthotics. The outcome measure was repeated ideally 2 weeks after the orthotic was provided to try and capture a true response within an appropriate time frame, bearing in mind the potential disease trajectory. So this shows the results of the ABC and related to patient function. There were varying results in this patient group, which was expected due to MND being a progressive condition. We anticipated a worsening disease trajectory, therefore any positive change was good, even if it wasn't significant. This graph here shows the average of all patients' responses to the ABC pre and post provision of their orthotic, presented as a mean. Questions 1, 2, and 8, which were talking about walking around the house, stairs, and walking outside to a car, showed statistical significance with increased confidence with p-values of less than 0.05. They had a medium and small effect size, as per Cohen's D. These tasks are more functional and more likely to be completed every day. These tasks are also more likely to be affected by an orthotic, for example, achieving foot clearance when walking and not catching toes when walking up the stairs. Questions 11, 12, and 13, as you can see on the graph, were not statistically significant. They're tasks that are less likely to be completed daily, so walking in crowded places, being bumped into, and walking up and down a ramp. It's also important to consider that an orthotic also reduces our available range in our ankle and also will decrease our ability to use our postural adjustment systems for balance because of the way that the orthotic is holding our ankle. There's no evidence as such to talk about the ankle strategy and postural adjustment systems with patients with MND and the use of orthotics affecting that. However, all of us use those systems, so we can assume that these patients would also implement these for balance. We didn't do any outcome measures prior to the initial meeting with the patient. Therefore, we don't know a change score for each particular patient, which would give us an idea of their specific disease trajectory. There's often a delay in these patients getting a diagnosis, as they may have presented with other symptoms and been through other care categories first before coming to a motor nerve clinic. There was also a bit of a delay in getting some of the patients' feedback. So ideally, we were looking to get patients' feedback within 2 weeks, and sometimes we waited 4 to 6 weeks to get the feedback as we weren't able to get through to the patients. So that could have affected the results. The results of the OPUS show that 95% of patients agreed or strongly agreed that they waited a reasonable amount of time to be seen. 100% of patients either strongly agreed or agreed that staff coordinated their care with therapists and doctors. And 10% disagreed that they were involved in the decision making. 35% agreed or neither agreed or disagreed. This could have been due to communication difficulties or difficulty coming to terms with disease progression or diagnosis, but also clinical reasoning used by professionals for the most appropriate fitting orthotic. There were no complaints or adverse incidents that happened as a result of the study. Indoor mobility, stairs, and outdoor mobility were statistically significant in terms of improvement for patients on average. It reduces non-urgent hospital contacts. Patients weren't coming back into hospital to go to an orthotic appointment, so that reduces also the infection risk of this vulnerable patient group. Reduces carer burden in terms of the patient's functional ability, hopefully prolonging their ability for longer, meaning they can do more things for themselves and be a bit more independent. Reduces appointment load. Lots of patients have lots of different appointments. If we can reduce the amount of times they're coming to hospital for different appointments, then that will have hopefully a positive effect. Reduces social care implications. It was quite challenging for patients to rearrange care calls, etc., to come into appointments. And then, with transport and things, it was a very long day for patients. That was a lot of the feedback that we got from patients themselves. So it worked much better having everything done on the same day within, the same kind of 5 hours or so. Potentially prolongs or maintains function and quality of life. And obviously there are financial benefits in terms of transport costs, coming to hospital less for less appointments. In terms of limitations, capturing data can be challenging due to potential communication impairments. We didn't use any qualitative feedback due to potential communication impairments, but also due to time and collecting the data. VAS scales, so a confidence rating scale, is very much open to interpretation. An 8 out of 10 for me might be very different to an 8 out of 10 for the next person. We use self-reported measures to avoid transport costs and face-to-face reassessments. However, this did limit the outcome measures that we could use with the patients. Other outcome measures we could have used, looking more at function of the 10-metre walk test, the timed up and go, the Berg. However, we tried to do all of our contacts by letter or by phone to get the results back to reduce all of the additional costs and stress for the patient. There are limited outcome measures specific to ALS, MND. The progressive nature of the condition means it can be quite difficult to capture appropriate data to support a new service. We had a small sample size, and the questionnaires that we used were not validated to capture quality of life. It's important to consider that outcomes don't necessarily change in terms of figures or the outcome measures that we use, but obviously real life does, and things change for the patients in terms of the quality of the life that they're living. Going on to future recommendations is to consider looking at compliance with different types of orthotics. So often the orthotists will provide things that aren't available to us. We'll often give lightweight orthotics and make personal adjustments for patients to make sure that they're easy to use, comfortable, and that the compliance is good. National bodies to define prompt and timely access to orthotics. A uniform approach across centres. The use of alternative outcomes, could have looked at carer feedback and different outcome measures, and then looking at to validate more ALS and MND outcome measures. We could also have a look in terms of other physio clinics and MND clinics and see what splinting stock they have available to them and their access to orthotics by way of a comparison. we could consider stocking potentially different orthotics within our physiotherapy service. I think the challenges that we would still have and still require an orthotist for is that a lot of these patients need kind of personalised orthotics or lighter weight orthotics or adjustments to them to make sure that they're fitting so that the compliance is best. Thank you for listening. Any questions?
I'm sure the physical therapists in the room have questions.
Thank you. Thanks for that. That was really interesting. It's not often until people actually go home that you can tell if a certain splinter or orthosis is going to work. If they needed to be adapted or reviewed, could they go to their local or do they need to come back to the clinic?
So it would always be that the patient would always be referred to their local orthotics service. But I think the background behind the project was that actually that was proving so difficult in terms of timely provision to kind of get there, that it is difficult to know, as you say, if the orthotic is going to fit appropriately, and we just kind of had to make the best in that situation and try and make it to, I guess, the best fit and anticipate any problems, because the follow-up of getting back to a clinic was probably equally as challenging as the initial kind of referral of getting to the clinic. So that's unfortunately not something that we have solved, and I'm not really sure what the answer is to that, because obviously waiting lists are huge and provision, it's tricky.
Thank you.
Any other questions? Yes. And if you don't mind just saying who you are and where you're from.
Oh, I'm Sharon Hallman. I'm from Vermont, the United States. So I envy that you have the national health insurance so you could provide the equipment at the clinic, which is something we don't enjoy here in the States. But the model of having the orthotist at the clinic, how do you know ahead of time which patients are going to be needing an orthotist? Do you have a process for screening ahead of time?
So what we did is we had the orthotist available at the end of the clinic. So the orthotist would be available from, say, 11:30 until 1 o'clock. So the patients would have come through the clinic at that time, and we would give them the choice of, they would only have time to see, say, 2 or 3 patients, but we could give them a choice of, would you like to be seen today? If so, are you happy to wait? Otherwise, we can do your referral to your local clinic.
Anyone else? I, of course, have a question. Do you think, I thought this was actually quite excellent, do you think you'll be able to affect the that timeliness piece based on some of the work that you're doing?
I mean, I would hope that it kind of raises the question a bit more widely. It's definitely, I think, work that in forums and things probably needs to be discussed, but I think from us personally as a centre, we need to now have a look at what other people are doing, and compare the services from different places now that we've got the one that we're happy with, and then see where we go from that.
For RN, you spoke mostly about the function, daily function that the orthotic really helps with. Do you think getting an orthotic early enough can prevent some of the contractures that we see on our patients already in wheelchairs, that they're already, because of the loss of the muscle, that they just have these contractures which are so painful and prevent them from even using their power wheelchairs if they were using their feet to control it? I have someone specific in mind. So, I
think it's one of those things that, yes, it's likely that if they had something appropriate to them, then hopefully in terms of contractures and things, it would slow down, kind of the process or the development. And again, as patients came through, we tended to have patients that needed things for ambulatory purposes, but there's definitely space for, additional orthotics to look at quality of life for other things, even if it's not using things in higher level functional tasks for, you know, the more specific things that you talk about.
Okay, thank you.